I got three great speakers here today. We'll start off by endoscopic bariatrics and metabolic therapy. What's the Skinny by Dr. Toby Zucchelli, who's a senior staff member at Henry Ford, and he's the fellowship program director for the advanced endoscopy and the director of bariatric endoscopy. So Toby.
Let's see here. What do we got? Which one goes? That one. Okay, cool. All right. Good morning, everybody. Thanks for coming out, and thank you to the MIGI. This is an honor to present here today. Truly appreciate it. And just, we all have this traditional disclosure slide, but mine's going to be, my kids are here in the audience. I love them very much. Thank you for coming. But if you guys hear fighting and yelling, it's just my kids. Don't worry. Everything's okay. All right, anyway, so I'm going to talk about bariatric endoscopy, and today we're going to review obesity, do a general overview of it, discuss current therapies for obesity, transition into endoscopic bariatric therapies, and then wrap things up with future directions. So as you all know, obesity is a complex metabolic disorder that causes significant morbidity, and over the past few decades, it's now more prevalent than malnutrition. And it's defined as a BMI of greater than 30, and it's broken down into three classes. Class 1, 2, and 3. And turns out we haven't been doing a great job in treating this disorder. The estimated prevalence is about 1 in every 3 Americans, so it's about 110 million people. And when we see the first decade of this millennium, we saw a 70% increase in people with a BMI of greater than 40, so we're getting heavier. And with nearly 1 out of every 5 U.S. healthcare dollars being spent to treat obesity, this is a significant problem we need to address. And the reason healthcare expenditure is so much is because obesity is a chronic disease that affects every organ system. So, with the main goal in treatment being weight loss, what are our options and how do we reach the masses? Well, traditionally we have our lifestyle modifications, which is going to be our diet and exercise. We have pharmacotherapy, and we have bariatric surgery. So when you look at lifestyle modifications, this is beat into us. This is the hallmark. This is the cornerstone for treating obesity. But we'll talk about this later. This is really something important to do, but it's really going to be your weight maintenance where you need to intervene with this. And, people can lose weight, maybe about 5 to 7% or so with a modest diet over a year. But they generally regain weight, and this can be a stressful, discouraging thing for patients who are trying to improve their quality of life. So we put a lot of emphasis on this, but we don't recognize the fact that this is something stressful, tough, just all around can be discouraging for patients. So we have to recognize that. So what about pharmacotherapy? Well, these are some of the FDA-approved medications, and it's indicated for people with a BMI of greater than 30 or greater than 27 with selected comorbidities. And if you don't reach a 5% total body weight loss at the 3-month mark, it's not unreasonable to switch medications. And we'll talk a lot about total body weight loss today. And really what that is if someone weighs 300 pounds, if you want to lose 10% of your total body weight loss, that's 30 pounds. So that's what the definition of total body weight loss is. And, some studies suggest that with medications, with high-intensity lifestyle interventions, you can hit 10% or greater total body weight loss, but most of these people will regain weight, especially how long do you keep them on medications for? So what about the new kids on the block? These are GLP-1s, and these really work by inducing satiety, and they lead to insulin release. And what that does is it leads to a slow emptying of the stomach. So essentially you're going to induce gastroparesis. And the weight loss we see with these medications based on the current studies is about 9 to 21%. But they have a bunch of side effects, gastroparesis, diarrhea, and these medications are contraindicated for people who've had pancreatitis before. But questions do arise about these meds. Do we use 2 together? What happens when you stop one, or when you stop the only one that you're on? When do you regain weight? Do you keep the weight off? And then furthermore, these are really approved for diabetes. So a lot of insurances have found that loophole, and instead of covering the medication, they're charging about $800 to $1,300 per month to get these medications prescribed. So what does the literature say? Well, if you look at it, there's been a lot of randomized controlled trials comparing medications, and if you add in ESG, which is here at the bottom, what we see is, pretty good total body weight loss from our GLP-1s, anywhere from 9 to 10 to 21%. But when you look at the metabolic benefits for these medications or pharmacotherapy, we see improvement in A1C, blood pressure, but we see a lot of adverse events, anywhere from 4 to 10%. We see a high dropout or discontinuation rate, and we see pancreatitis, as we know about in these GLP-1s. When you compare that to ESG, I don't know if this will work, down here at the bottom, what we'll see is we see a low discontinuation rate, low adverse events, improvement in the metabolic parameters, and pretty much similar total body weight loss compared to pharmacotherapy. So really, when you think about it, ESG kind of trumps these medications here. So what about bariatric surgery? You guys are all familiar with this. It is superior to lifestyle modifications and pharmacotherapy to treat obesity, and it's reserved for patients with a BMI of greater than 40 or greater than 35 with a selected comorbidity. You guys can check. Blue Cross of Michigan, I think, has approved obesity surgery for people with a BMI of greater than 35 recently without comorbidities, so it does open up a higher selection pool for the surgeons. So what are our main interventions? Well, no one's really doing a lap band anymore, so we're really stuck with a Roux-en-Y or a sleeve gastrectomy. And as you all know, Roux-en-Y causes a lot of therapeutic dilemmas for endoscopy. It's an invasive procedure, but it does offer the maximum total body weight loss out of the surgical interventions. And a sleeve is a great procedure. It's minimally invasive. It's short for the surgeons. But as we found out, there's about a 40 to 60% de novo rate of GERD for these patients. So it is causing a lot of morbidity and concerns about Barrett's in the future for patients with sleeves. And undoubtedly, bariatric surgery is a game changer. We saw a 40% decrease in mortality, death from CAD, diabetes, cancer. So why doesn't everybody get bariatric surgery? Well, there are a multitude of reasons. There's adverse events. There's a reoperation risk. There can be costs depending on the patient's insurance. It's generally not reversible. There are limited centers of excellence throughout the country. What about our gray zone patients, which we'll talk a lot about today? There's BMIs at 30 to 39, new onset GERD, and let's face it, patients don't want to undergo surgery. They don't want to lose an organ. They want to get help and move on with their life and not be admitted to the hospital for 2 to 3 days afterwards. So with the obesity map in the United States heating up, and with a marginal number of people undergoing bariatric interventions, something has to change. And how do we bridge that gap between surgery? This is one of our bariatric surgeons at Ford. Pharmacotherapy and lifestyle interventions. And the answer is clear. It's bariatric endoscopy. I haven't had breakfast, so this slide looks great. And when we talk about weight loss interventions, really our standard should be a goal of losing 10%, okay? That's the magic number. When you lose 10% or more, you're going to see reversal in the metabolic parameters. And that is the main goal for these patients. We want to prevent morbidity and mortality in the future. And the evidence is becoming clearer. For weight loss, you kind of have to start at the top. I'm not an IBD person, but top-down therapy. So we're going to start at the top here with interventions. So bariatric surgery or bariatric endoscopy to achieve this greater than 10% total body weight loss. Whereas when we start dealing with weight maintenance, this is where pharmacotherapy and lifestyle modifications are absolutely key. Oh, my mom's calling me. All right, so advantages to endoscopic bariatric therapy: it's an outpatient procedure, there's no scarring, you spare the organ, there's less adverse events than bariatric surgery, it's minimally disruptive to life because this is an outpatient procedure, and it's a viable option for patients who are poor or non-surgical candidates. It can bridge to surgery, and it's, let's face it, where liver disease is going is NAFL and NASH, and this is an intervention that can tremendously help these patients, especially when they develop hepatomegaly and surgery may not be an option. So what are our bariatric therapies? Well, we have an endoscopic sleeve, which I'm sure you guys are all familiar with. We have our space-occupying devices, and we'll talk about those momentarily. And then there was aspiration therapy, and much to the chagrin of Colbert, aspiration therapy is no longer FDA approved. I mean, probably a good thing. And then there's also secondary endoscopic bariatric therapy. So this is for patients who've had bariatric surgery and have developed weight regain. And this can be your transoral outlet reduction. It's been known as the revised procedure, or closure of a gastrogastric fistula. And due to time constraints, we won't talk about these today. So what limits EBT? So what limits bariatric therapies? And it's what makes the world go round. It's all about the money. So these were traditionally a cash pay procedure, and that paradigm has recently changed, and we'll talk about why here momentarily. So what are our space-occupying devices? Well, the FDA has approved 3. There's our fluid-filled intragastric balloon, there's a swallowable air-filled intragastric balloon, and then there's a transpyloric shuttle. And these are approved for BMIs 30 to 39. Total body weight loss is kind of all over the map, but it's generally around 7 to 12%. And balloons are to be removed in 6 months. The transpyloric shuttle is at 12 months after implantation. So we see improvements in metabolic syndrome, diabetes, hypertension, hyperlipidemia, liver histology, and NASH based on current studies, as long as you get over 10% total body weight loss. And these space-occupying devices, they do come with adverse events. There can be nausea, balloon migration, perforation, pancreatitis has been reported. And in 2017, the FDA issued a statement regarding 5 deaths associated with balloon placement. These balloons were placed, all 5 deaths occurred within 1 month of balloon placement, and three patients passed away 3 days after balloon placement. They don't know why, but there's an association, and the FDA released this. So for me, space-occupying devices, they're not the future. They're a nice tool to have in the armamentarium, but I think where we look at endoscopic sleeve. And what an endoscopic sleeve really does is it does 2 things. It reduces the capacity, so the volume of the stomach, by about 70%. And more importantly, based on more and more studies, it shortens the stomach. So the last sleeve I did, I shortened the stomach by 10 to 11 centimeters. And what that does is it leads to a delay in emptying. It induces early satiety. We keep the fundus intact. We don't lose any de-innervation, so we don't have any issues with heartburn like a surgical sleeve does. And this is ideal for patients with a BMI of 30 to 49, and they must be willing to participate in diet and weight loss programs. So we do have an election year coming up, so I figured it'd be nice to kind of debate the merits of endoscopic sleeve. And I'm really going to base this on 4 questions. Is it better than high-intensity diet and lifestyle therapy? Is it better than bariatric surgery? Is it reproducible with an acceptable adverse event profile? And is it safe and efficacious at achieving and sustaining weight loss? So let's look at an article first. This was published in GIE out of Hopkins, and it compared endoscopic sleeve versus high-intensity diet and lifestyle therapy. And it was a case-matched study looking at 105 patients matched for BMI, and the high-intensity diet group had a diet of 800 to 1,200 calories per day. So really tough right off the bat. It's really hard for anybody to be at that degree of caloric intake. They had an intense physical activity, and they had further lifestyle modifications that were driven. And what the study found, to no surprise, is that 30 to 60% were non-compliant and did not follow up in the high-intensity lifestyle group. And in the ESG group, there was significant improvement in total body weight loss, especially for those patients with a BMI of under 40, so that 30 to 39 range. So what about, is ESG better than surgery? Well, it depends if you ask a surgeon or a gastroenterologist. So based on a few of these studies, if you ask a surgeon, they're going to tell you that the total body weight loss with the sleeve is better, and they're exactly right. It is higher. But they're not going to tell you about the increased length of stay after surgery. They're not going to tell you about the increased amount of GERD. And they're not going to tell you about the increased number of adverse events that ensue compared to endoscopic sleeve. So let's just call this one a push for now. So what about, is it reproducible? And this was a nice study. Looked at about 112 patients at 3 centers. Then they achieved a total body weight loss of 8% in 1 month, over 10% at 3 months. And that's kind of based on the literature at the 3-month mark. We want to see people, and we consider them responders, if they're losing greater than 10% at the 3-month mark and 15% at 6-month mark. And half of the patients achieved a total body weight loss of greater than 10% at 3 months, and the results were all similar between centers. And then this study was published a few years ago in GIE. It was out of Saudi Arabia. It looked at one surgeon who was doing endoscopic sleeve there, and he did 1,000 consecutive patients. So thanks for that data. So what did his study show? Well, if you look at the 3 and 6 month mark, we're seeing a total body weight loss of greater than 10% at 3 months, about 14% at 6 months, and the sustained benefit is there. We look at the year mark, we're at 15%, and we look at the 1.5-year mark, we're still about the 15% mark for total body weight loss. And then our North Star paper came out in 2022. This was the MERIT trial. I'm sure everybody's heard of this. But this looked at 85 patients who underwent ESG at 9 centers and compared them to 124 patients who had lifestyle modifications. The average BMI was similar between the groups, and 84% of the patients achieved a total body weight loss of greater than 10% at the 2-year mark. So we're having sustained benefits. And what they did in this study was really nice is if the average total body weight loss, so the average total body weight loss for the ESG group was 14% at the 1-year mark, and significant weight loss, as we mentioned, was maintained 2 years later. There's someone back there. The next slide won't advance. But, thank you. So on this next slide, their target goal was an excessive weight loss of greater than 25%. And the ESG group achieved this. Their excessive weight loss was 49%. And the total body weight loss was about 16% among responders. So that's the patients at the 3-month mark who had a total body weight loss of greater than 10%. And what they did here, which was really nice, is they had a crossover point. So the graph on your visual left shows that the people in the high-intensity lifestyle modification group at 52 weeks were crossed over into endoscopic sleeve. And those crossover groups, you can see, parallel the ESG group. So even in people maintaining diet, ESG works. And what did the MERIT show? Well, it showed improvement in diabetes, improvement in hypertension, and overall improvement in the metabolic syndrome with a low adverse event rate of about 2%. There was 1 GI bleed treated with endoscopy, 1 perigastric abscess treated with endoscopy and antibiotics, and 1 patient who had malnutrition treated with endoscopic reversal. So overall, they met the primary safety endpoint as well. And this led to, last summer, the FDA releasing this, which approved ESG and the revised systems for endoscopic bariatric therapies. And this will be coming in July. A CPT code will be coming for the procedure. And generally, when CPT codes come, insurance follows. And hopefully, this will open up patients to a procedure that has been proven to be safe, efficacious, and have a low adverse event profile. So my case for ESG, is it better than high-intensity diet and lifestyle therapies? Yes. Is it better than bariatric surgery? Well, I'm a gastroenterologist, so yes, it definitely is. Is it reproducible, and is there an acceptable adverse event profile? Yep. And is it proven benefit over a sustained time frame? And I would say, you look at the MERIT trial, and by the way, I forgot to mention, MERIT was done in the midst of COVID, so they had sustained benefits when the world was, at its scariest. So what are the keys to an ESG program? Well, there's probably 5 tiers. So you need to have a supported endoscopist, someone trained and qualified to do this. It can be a surgeon, general endoscopist, therapeutic. You have to have support by your bariatric surgery team, your behavioral health. You should have a medical obesity specialist to help you out there, as well as a dietitian. And this is the procedure. So I know you guys all know what the stomach looks like, but this is a little prolonged. So that's the greater curve. We're starting to ride the greater curve, and we're looking at the anterior wall to the posterior wall below. And we're going to bring the anterior wall, greater curve, and posterior wall together to, again, try to reduce the stomach by about 70%. And you don't have to, but most of us will start by marking the anterior wall with APC. And the reason we do this is, when you do suturing, you're putting a full thickness suture and there's natural oozing or bleeding that occurs with it. So once you mark the anterior wall, you're going to mark the posterior wall here. And this is going to serve as your map or your outline to do your reductions. So we have both walls marked, a little more touch-up work here, and you can kind of see the contour and what we want to bring together. And traditionally, most of us will use a U pattern. Some will use a Z or a zigzag pattern to try to shorten the stomach. And we all use this helix device. It's like a corkscrew that goes through your double channel scope. It brings in the tissue or the mucosa so that you can put a full thickness suture. And this is important. To achieve a full thickness suture, you got to use the helix. And it also makes it a safer procedure because you don't want to grasp a surrounding organ. So here we have our first suture. We're starting at the junction of the antrum body. We're giving a little slack. We're doing a needle exchange so that we can continue to suture. And then again, what we're going to do is we're going to put out our helix. We're going to grab some tissue. We're going to tell our nurse or assistant to turn it 3 to 4 times to the right. And then once that's done, you're going to pull back. You're going to adjust your scope here. I'm rolling left there so I get a perpendicular bite through the gastric wall. And you're going to do your needle exchange. You're going to unhelix or rotate 3 to 4 times to the left. And then you're on your way. And you're going to just keep following this pattern until eventually we have to uncross. You're going to drop your needle, which is going to serve to anchor one end of the suture. So you drop your needle there. And then you find the strongest person in the room, and you're going to use your cinching device. The cinch is another corkscrew or another like white tag that you're going to use. And you're going to put it on this wire here momentarily. You're going to shrink down the stomach, kind of pull the slack out of your suture line a little bit. And then you're going to go ahead and put in the cinch here, hopefully soon. And there's the cinch. So you want to have at least 3 of these rings out when you're using the cinch. You find the strongest person because it takes 2 hands to close this cinch. And you're going to have them deploy, and this is going to complete your suture. It's going to tie it on both ends. So momentarily that will happen here. Pulling out kind of some of the slack in the line. We're going to drop it to the suture. It's released, and you can see the first row is done. And 2 things you notice here. The lumen is more tubular, and it's pulled together, and it's shrinking in size. So eventually you're going to get anywhere from 6 to 8 rows of those sutures. This one, I got the distal body a little too narrow, so we're coming through, and we're going to see that area there, the little edema, which is natural after suturing. And you're going to keep coming back, working proximally, and you're going to see your sleeve here. You can see this shortened tuberalized stomach, and you're going to take this to the GE junction, which is about there. You're going to see your fundus is intact, which is important with this procedure or this intervention. And then you finish. Okay, so what about combination therapy? I think that's a natural next thought, combination therapy with GLP-1s. Well, this study was presented at DDW this year. Hopefully you guys aren't talking about this. Maybe you are? Okay, good. So I'll skip it. I'll save Roberto here. But this study was presented in 2021 at DDW, and it compared GLP-1 with ESG versus ESG alone, and it did have a significantly higher total body weight loss at the 11-month mark. So there is some benefit to this. So what about the future? Just wrapping things up here. Well, we're still waiting for FDA approval on this device here. This is our POSE-2, or it's also known as your incisionless operating platform. And it also uses a corkscrew device to pull in pieces of the stomach to give these sutures full thickness plication here. We have our EndoZip out of Israel, and this is passing this bougie over a pediatric endoscope. And you can see there's some coils in the white part of the tip of the scope there. And that's going to rotate and deploy full thickness sutures. And this procedure is pretty straightforward, and they're looking at about a 14 to 15% total body weight loss. This is being developed by Dr. Abudaya at Mayo. Basically what it is a gastrojejunectomy, either surgical or endoscopic, followed by something to occlude the pylorus. And then you have a single anastomosis here. And then from there, see if you can lose weight with medications or do an ESG on top of it to further lose weight and try to mimic a Roux-en-Y bypass as much as possible. And on the metabolic forefront, we have this device from Endogenics, and it really goes in and rewires the signaling system in the duodenum so that it improves insulin resistance. And they're reporting early data that's looking at about a 1% or 1 point A1C decrease. And I think the main future direction will be finding out which patients are responders versus non-responders to endoscopic bariatric therapies and triaging them appropriately. So just to wrap things up, obesity is a global epidemic that leads to significant morbidity. GLP-1s may be the tip of the iceberg for pharmacotherapy, but sustained weight loss is questionable. EBT is a good option, but you got to get that 10% total body weight loss. EBT represents a promising option for a treatment for our NASH patients. And endoscopic sleeve represents good weight loss option for a large number of patients. And hopefully with this CPT code coming, we can all help out a lot of people. The MERIT trial has provided the data for FDA approval, and the future of endoscopic bariatric and metabolic therapies on the rise, and more products and interventions will continue to follow. Thank you.
That was great, thank you. Okay, we'll save questions to the end. So, you go next, Eugene? Okay. Our next speaker is Eugene Zolotarevsky, fondly known as Dr. Z. Did I pronounce it right? So he's out of Corwell West, formerly Spectrum. He's the director of interventional endoscopy there, and he'll be giving us some updates from DEW for advanced endoscopy. Eugene?
Good morning, folks. First, I wanted to say thank you to the directors for giving me an opportunity to talk. This is truly a great course, and I appreciate you guys staying till the end. So my talk is going to be on updates from DEW and advanced endoscopy, and specifically I'm going to focus on interventional EUS component of it, at least the latest, greatest hard-hitting abstracts that were done. This is my obligatory disclosure slide. The first abstract that I'll talk about is, in summary, gastric emptying and enteral stents versus EUS gastrojejunectomy. Over the last 3 or 4 years, there's been ample amount of data suggesting that EUS gastrojejunectomy is a superior procedure in palliating patients with malignant gastric outlet obstruction, and especially in patients who have long-term survival or expected long-term survival over 3 months. These stents tend to outperform enteral stenting. But in the short term, there's no data comparing both modalities in terms of outcomes. So this is a study from a tertiary referral center from India, where they took consecutive patients who underwent enteral stenting and had EUS gastrojejunectomy. And then they systematically performed 4-hour gastric emptying studies in all of these patients at 2 weeks to study how they do after both procedures. So interestingly enough, they were able to show that in 12 and 14 patients with gastrojejunectomy and enteral stenting, that gastric emptying was significantly better in the EUS gastrojejunectomy group compared to those who had enteral stenting. And only 1 patient had delayed emptying in the gastrojejunectomy group compared to 6 patients who had enteral stent placement. Their clinical symptomatology indices were better in the gastrojejunectomy, but they did not meet statistical significance. And they postulated that this probably has to do with the fact that while you can restore luminal patency in these patients, that is still insufficient in achieving improved gastric emptying, as opposed to if you have a gastrojejunectomy in a similar manner as a surgical gastrojejunectomy, there's more of a direct route for the food bolus to pass into the small intestine, and that may be why these patients do better. To highlight this point, this is one of the patients from our center who had a young lady who had a complicated segment 4B malignancy that obstructed the antrum. And in the slide to the right, or the picture to the right, we placed a gastroduodenal stent and then subsequently we were able to cross into the duodenum and place a biliary stent in this patient, but still she remained symptomatic, and you can see on her upper GI series, she still had quite a bit of retention and was never had a good clinical outcome. We wanted to do a gastrojejunostomy, but unfortunately this patient expired shortly after this. So in conclusion from this study, delayed gastric emptying is more significant in enteral stenting compared to EUS gastrojejunostomy, and this may explain improved short-term outcomes with EUS gastrojejunostomy. And of course, previous data has suggested that long-term outcomes are superior with this modality as well. The second study is on a topic of EUS gastrojejunostomy for biliary access. Now, this is a multi-center retrospective study which was done in 5 tertiary referral centers in patients who had pre-existing EUS gastrojejunostomy for malignant gastric outlet obstruction, and they later required a biliary access for biliary obstruction. Majority of these patients, 84%, had malignant biliary obstruction, and most common site of gastric outlet obstruction was in the D1. These were not healthy patients. 20% had peritoneal carcinomatosis, and about 2/3 of these patients had native papilla, no previous biliary instrumentation, so there's added complexity to this. So in terms of their outcomes, they were able to show that overwhelming majority of the patients, they had successful biliary access in about 93% of the patients. 76% of the patients in this study were done using an ERCP scope. So for those who do ERCP, this is very similar in doing a Billroth 2 ERCP. They would essentially go through the enteral stent, go retrograde through the duodenum, and access the papilla that way. In 4 patients, they did a same session gastrojejunostomy and then followed with ERCP. 3 of these patients were successful. They quoted 1 patient who had a migrated LAMS, and majority of these patients, like this patient, had a well-formed anastomosis. So in those cases, you can just replace the LAMS, and these patients do just fine. In conclusion, utilization of EUS gastrojejunostomy is safe and effective way to perform biliary interventions in patients with gastric outlet obstruction. This is one of the patients from our group. You can see we're using a 1T therapeutic gastroscope with a distal attachment device that does not show very well on this image. We actually removed the LAMS because that facilitates our ability to navigate in retrograde manner into the duodenum, and then we were able to achieve deep biliary cannulation and stent this patient, and they did well afterwards. The next study that we have is on the topic of transjejunal ERCP and Roux-en-Y hepatojejunostomy. Many of you are aware that EDGE procedure has been revolutionary in patients who have Roux-en-Y gastric bypass and need biliary access. However, in Roux-en-Y hepatojejunostomy, this is a vastly different post-surgical anatomy and has very different challenges. So in this particular study, these are patients who, most of them had liver-related surgery and ultimately underwent a Roux-en-Y hepatojejunostomy, and then in a median of 7.4 years later required biliary intervention. 88% of these patients had benign reasons for needing biliary intervention, including stones, hepatolithiasis, and anastomotic strictures. And 74% of these patients had previous attempts at biliary access, either by percutaneous route, by PTC, or using balloon-assisted technique, balloon-assisted enteroscopy technique, but both of which were not successful. And then they went to this technique as a salvage modality. So most of these patients, they placed a 15-millimeter lumen-opposing metal stent, and then, or they also mentioned that they did this using a freehand deployment approach, and certainly I can discuss that part of the technical part of that in a different setting. But in terms of their results, they were very successful in this procedure, 94% having deep biliary access. Same session ERCP was done about 40% of these patients, so they went, did the reversal, and then went right through the jejunal stent and did the ERCP part. The most common connection was gastrojejunostomy and duodenojejunectomy. In a few cases, they ended up doing a jejunojejunectomy to achieve access. The complications always, the point of discussion in these very complex situations. They did have one perforation and they did have 5 LAMS dislodgements. They were able to manage all of these medically and endoscopically without requiring surgery, and everyone did well. When they looked at long-term outcomes, 80% had long-term success, which they defined as 30 days later in achieving their stated outcomes, specifically if there was biliary obstruction, elevated liver enzymes, treatment of strictures, etc. So in conclusion, EUS enteral anastomosis-assisted transjejunal ERCP appears to be a safe and effective option. Technical success rates may be higher than enteroscopy-assisted ERCP and percutaneous IR approaches, and they concluded that based on the fact that majority of these patients were failures of those 2 procedures. This is a particularly interesting study. The topic is EUS colodocoduodenal stenting in resectable distal malignant biliary obstruction. This was done in France. They took patients with resectable disease, specifically pancreatic head malignancies, distal cholangiocarcinomas, and ampullary cancers, and they decompressed these patients either by standard route using transpapillary access by ERCP with biliary stenting, or a more novel approach using colodocoduodenal stent using a 6-millimeter LAMS, and then all of these patients were followed by a Whipple procedure. Some of these patients had failure to cannulate and they were crossover, but for most part we can kind of look at their outcomes. So they were able to conclude from endoscopic outcome standpoints that CDS, colodocoduodenal stenting, was technically and clinically more successful than transpapillary stenting. They had higher complication rates in ERCP group, but that did not reach statistical significance. Pancreatitis rates were typical, 10% in the ERCP group. One patient who had a colodocoduodenal stent ended up having pancreatitis, which they attributed to doing EUS FNB of a pancreatic head mass. What's striking, and I think from an oncologic standpoint, is that the patients that were eligible for upfront surgery had delays in surgery that were more significant in the ERCP group compared to the CDS group. And they specifically stated that patients who developed post-ERCP pancreatitis had delays, 11 out of 12 of them had delays for more than a month in going to an operation. So that's quite significant. When they looked at surgical outcomes, overall surgical complications, when they looked at surgical kind of compounded rates of all surgical complications, they were higher in the ERCP group. But what's really striking, this is kind of what concerns our surgeons with this procedure, is there going to be an R0 resection with a colodocoduodenal stenting? In this study, R0 resection rates were identical between the 2 groups, and overall survival was no different in patients who had colodocoduodenal stenting or who had ERCP transpapillary stenting. So in conclusion, EUS CDS is associated with higher success, less complications, less delays in oncologic therapy, and less surgical complications after pancreatic duodenectomy without compromising oncologic outcomes. We in our group have not employed this strategy yet. I think more studies are needed, but I think it's definitely very interesting. We do quite a bit of colodocoduodenal access. This is a particular patient who had unresectable disease and had dual obstruction concurrently of duodenum and the biliary tract, and we ended up placing a duodenal stent and a transduodenal LAMS that went into the biliary tree. You can see a very nice air cholangiogram there. The last abstract, and I'll run through this quickly because I'm running out of time, is interval cholecystectomy after EUS-guided gallbladder drainage with LAMS. Now, EUS gallbladder drainage is an effective procedure, and it's probably more effective than percutaneous drainage of the gallbladder, but it's been reserved to patients that will never be surgical candidates, and primarily because surgeons don't want to deal with gastric or duodenal fistula to the gallbladder. This study actually wanted to test this issue, and they did 81 patients. They did cholecystectomies in patients who had prior gallbladder drainage with LAMS, and they had 6 months follow-up. So endoscopically, all were technically successful with very mild endoscopic complications. A majority of the patients had coldocoduodenal access, and some patients, majority of the patients had transduodenal access to the gallbladder, and minority of the patients, 30%, had transgastric access. Median length of indwelling transmural stent was about 3 months, and they removed these LAM stents about 4 days prior to cholecystectomy. In 5 cases, they actually did it intraoperatively. So then the next question is, how do you manage these fistulae? So initially, they started suturing these patients endoscopically, or placing Ovesco clips, or placing through the scope clips, and they quickly realized that was absolutely not necessary. So 86% of these patients had no endoscopic closure of the fistula after LAMS removal, but instead, a majority of these patients had surgical closure. So intraoperatively, they either did laparoscopic suturing, or they just ran a stapler across the fistula, and they were able to take out the gallbladder successfully. Interval cholecystectomy feasibility was 100%. They had 2 patients that converted to open. Median operative time was 44 minutes, which is in line with typical laparoscopic cholecystectomy. They had long-term follow-ups, and their adverse events, they had 2 subhepatic collections that required antibiotics and drainage, and 1 patient had a transection of the common bile duct that required same-session hepatojejunostomy. But this is in line with typical expectations from cholecystectomy surgery. So in conclusion, EUS gallbladder drainage seems to be a feasible and safe alternative to percutaneous drainage for interval cholecystectomy. EUS gallbladder drainage should probably not be limited only to patients who are never surgical candidates, but probably can apply to patients that may be eligible for interval surgery. So with that, I'm going to conclude, and sorry for going over a couple minutes.
A lot to digest and discuss. That's great. Okay, our last talk for this session will be also updates from DW by Dr. Roberto Gamara, who's a well-known interventional endoscopist in Southeast Michigan, is trained under the tutelage of Dr. Geenan and Catalano. So he's mostly out of Ascension, Providence. Roberto?
I'd like to echo everyone's appreciation to the course directors and to the audience also for staying late. I have no disclosures. I'm just going to go over 6 of the hot, what I found to be hot presentations from DDW, focusing on non-EUS studies. So this first one's the evaluation of AI-aided endoscopic diagnosis on improving endoscopy quality and learning curve in beginning colonoscopy trainees. So I wanted to include this because AI seemed to be a very hot topic in every breakout session during DDW, and I thought this was an important one to include. So what we know is that many AI systems have shown improvement in adenoma detection rates for endoscopists. So the aim of this study was to evaluate whether CAD-I, which is one AI system, whether it improves the quality of colonoscopy and expedites learning curve in trainees by comparing ADR as well as adenoma miss rates. So this was a multi-center randomized trial between May of 21 and March of 22, where patients were divided into a CAD-I group A group, or group B, which was just white light endoscopy. They had 6 trainees in their 3rd and 4th years after graduation and performed back-to-back colonoscopy in pairs. Their primary endpoint was adenoma detection rate, and they had secondary endpoints of adenoma miss rate, as well as a 14-point assessment of competency in endoscopy tool scores. So there were 231 cases, 113 in group A and 118 in group B. There was no difference in adenoma detection rate between A and B, but there was significantly lower adenoma miss rate of 26.6% in the CAD-I group compared to the almost 40% in the white light group. And the number of missed adenoma rates per patient was also statistically significant between groups A and B. Group A also scored significantly higher in 2 items of the 14-point competency in endoscopy tool score, and that was pathology identification as well as identifying location of pathology. So in conclusion, the use of cat-eye in colonoscopy can consistently decrease the adenoma miss rate in trainees in gastroenterology. And the use of cat-eye may improve the ability to accurately locate as well as identify the type of colorectal adenomas in trainees. Second study was on ESD in IBD, and this was a French retrospective multi-center study. We know that while there's been a decline in the rates of IBD-associated colorectal cancer over the past 20 years, there's been an increase in IBD-associated dysplasia incidence rates. ESD has been validated for R0 as well as curative resection of sporadically laterally spreading lesions, and the feasibility of ESD and IBD has been studied as well. So the aim of these investigators was to study and assess the short-term and long-term efficacy of ESD for visible dysplasia in IBD patients. This was a retrospective multicenter cohort study which included consecutive ESDs in IBD patients with visible dysplasia. The primary outcome was R0 resection, and but they also looked at en-bloc resection rates, curative resection rates, complication rates, recurrence rates, need for surgery, and several others. So there were 88 lesions in 83 patients, including 23% were Crohn's patients and 76% were ulcerative colitis. The mean follow-up was 26 months, and the median IBD duration was 21 years. En-bloc resection, R0 resection, and curative resection were achieved in 91%, 80%, and 80% respectively. There was 8% bleeding and 15% perforation, but only one of the patients required surgery. And there was 4 patients, or 5%, that had local recurrence. There was statistically significant association with recurrence in patients who had a personal history of colon cancer, PSC, current inflammatory activity of the IBD, and incomplete resection, which is not surprising. Traction strategy was required in 60%, and it provided higher en-bloc resection rates of larger lesions, fibrotic lesions. High volume centers, which was defined as those that perform more than 100 ESDs per year, performed better, larger and faster resections with fewer recurrences. And there was more recurrence in patients with Crohn's disease, up to 26%, compared to ulcerative colitis, which was only 3%. So in conclusion, this was the largest worldwide cohort study for ESD and IBD-associated dysplasia. En-bloc and R0 resections were over 80%, which is close to that obtained for ESD and sporadic neoplasms. The perforation rate was 14%, but was higher, confirming more complexity of this cohort, and it should be reserved for high volume centers. Thankfully, perforation was very low. Perforation that required surgery only occurred in one patient. Traction strategy results in higher rates of complete resection. This next study was a POEM study looking at the rate of GERD in POEMs. As we heard earlier in this course, POEMs is important procedure now for achalasia. The benefits of POEMs, however, have been tempered by the risk of post-POEM reflux complications. So these investigators tried to evaluate the long-term impact of post-POEM reflux at a single center. This was a retrospective study of prospectively collected data in consecutive patients undergoing POEMs for 10 years. They performed follow-up visits routinely at 3 months, 12 months, 2 years, 3 years, 48 months, and then finally at 60 and 72 months, so annually up to 6 years. The post-poem, they included Eckhart scores, quality of life scores, EGDs, high-resolution manometry, and pH studies throughout their follow-ups. The results included 361 of 522 POEM patients underwent pH monitoring. The abnormal acid exposure was noted in almost 50% at 3 months. There was reflux esophagitis as well as and grade C and D esophagitis in 40% and 4.6% respectively at 3 months. But this seemed to go down to 34% and 2% at 36 months. And by 6 years, it was 20% and 0%. Heartburn and regurgitation, interestingly, did not go up over the study period, did not go down over the study period. And only 2% had symptoms on a daily basis. Daily PPI use was noted in about 50% throughout the study period. And there were no cases of Barrett's or esophageal cancer afterwards. So in conclusion, the rate of post-POEM reflux esophagitis seems to decrease over time. However, 50% of patients require long-term anti-secretory treatment. Severe reflux complications are rare, but post-POEM patients should undergo long-term surveillance. I wanted to include this other POEM study because this was POEMs being applied to patients who do not have achalasia. We know that POEM has emerged as a promising technique for non-achalasia esophageal motility disorders, and these were defined as hypercontractile esophagus and distal esophageal spasm. Given the generally normal LES in patients with these conditions, preservation of the LES may reduce post-POEM esophagitis while still maintain efficacy, and this is what these authors wanted to study. They labeled this the less POEM procedure. So they'd perform a POEM, but not sacrifice the lower esophageal sphincter. This was a prospective observational study, and they included Eckhart scores at 6 months, 1 year, and 2 years post-POEM. Follow-up EGD was performed at 6 months, and the primary outcome was clinical success, which was defined as an Eckhart score of 3 or less without any reintervention. Secondary outcomes included esophagitis at 6 months post-EGD. The results included, there were 18 consecutive patients from 2015 to 2021. 10 of them had hypercontractile esophagus. 8 had esophageal spasm. The median pre-POEM Eckhart score was 6 and decreased to 1 at 6 months, and that was sustained at 1 year and 2 years post-POEM. 1 patient progressed to achalasia type 3 and required a POEM of the lower esophageal sphincter. 2 patients, or 11%, had esophagitis, only grade A or B at follow-up, and there were no serious adverse events. So in conclusion, POEMs with LES preservation for non-achalasia esophageal motility disorders does not compromise clinical outcomes after 2 years of follow-up. 6-month control endoscopy showed esophagitis is rare with this condition. This next study, which I'll go through quickly, was G-POEMs in lung transplant patients. We know that gastroparesis is common in this subset of patients, likely due to many reasons, including delayed gastric emptying from reflux, microaspiration, immune system activation, lung injury, as well as allograft rejection. And G-POEMs is recommended for refractory gastroparesis by various societies. So these authors wanted to evaluate whether G-POEMs resulted in good outcomes in patients with refractory gastroparesis and lung transplant patients. It was a meta-analysis of all studies until 2022, which reported clinical efficacy and gastroparesis cardinal symptom index, GCSI, in pre and post G poems. The results included 4 observational studies of 104 patients. The pooled estimates for clinical efficacy of G poems was 83%. The pooled mean reduction of GCSI following the procedure was a drop in 2 points, and gastric emptying study retention was significantly improved after G poems. Adverse events included 4% of major bleeding, 6% minor bleeding, pyloric stenosis, and 1% reflux at 1% reflux. 90-day mortality was 2.6%, with 1 patient passing away from allograft rejection. So the authors concluded that G poems was effective and safe for lung transplant patients with refractory gastroparesis. So I'm going over in time, but honestly, this was probably my favorite study presented at, and this is the one that Toby alluded to earlier. Endoscopic sleeve gastroplasty in this study was studied with and without anti-obesity medications. So they wanted to assess the efficacy and timing of combining ESG with various anti-obesity medications and compare it to that of either monotherapy with ESG or medications. So this was a single center study, retrospective, and it categorized the patients into 3 groups. One was ESG only. The second group was a combination of anti-obesity medications with ESG, and that group was further subdivided into anti-obesity medications first, followed by ESG, or ESG followed by anti-obesity medications within 6 months of each other. And finally, there was sequential therapy, which was anti-obesity medications over 6 months after ESG. The outcomes included total body weight loss at 12 months and the success rate of greater than 10% total weight loss at 12 months, as well as serious adverse events. So there were 224 patients, 34% were in that group 1, 31% in combination group, and 35% in sequential group. Among the combination therapy patients, 30% were prescribed a regimen that included GLP-1 agonists. So this is the Wegovy and the Ozempic and Mounjaro drugs. I guess I'm not supposed to use the names. 30% were prescribed a regimen that included those drugs. In sequential therapy group, 81% were prescribed anti-obesity medications greater than 6 months prior to the ESG, while 20% underwent ESG first. So at 12 months, patients who had ESG plus the GLP-1 receptor agonist combination experienced the greatest weight loss of 23% compared to the monotherapy group. Patients started on an anti-obesity medication followed by ESG over 6 months, later experienced the least amount of weight loss, and it's not really clear why that was. While 100% of the ESG plus GLP-1 combination group experienced greater than 10% total body weight loss, only 56% had achieved that threshold in the arm that had anti-obesity medications followed by ESG. The side effects were low, and they were similar among all 3 groups. So these were the tables that were included. So the first, the blue arm, if you look, the blue column is the best total body weight loss which was 23% in patients who had ESG and GLP-1 agonists. Then you had the combination therapy of non-GLP-1 medications. So you see the rest of them were somewhat similar, whether they got non-GLP-1 agonists versus ESG alone. And the worst was anti-obesity medications followed by ESG. So in conclusion, the combination of ESG plus GLP-1 agonist is superior to ESG alone. The optimal time to adding on anti-obesity medications is within 6 months of ESG. And for some reason, being on anti-obesity medications greater than 6 months prior to ESG was a predictor of poor response following the procedure. That's it.
That's great. Okay, would like to open up for discussions. And while we're waiting for discussions, Toby, let me start with you. Oh, I'm sorry. Up in the front.
That's fine. So we've been kind of looking at how do we now account for these GLP-1s in patients that are undergoing endoscopy. Have you all been doing or considering a different approach to either their NPO status because of the delayed gastric emptying, or what anesthesia is doing at Mayo Clinic is intubating everybody, which is obviously making that procedure from a, sort of an overall low risk procedure to a higher risk procedure, just based on the fact that they're on a GLP-1?
Yeah, great question, and very, very important to recognize this for patient safety. What we're doing at Ford is run by Eva, so my smarter half is running the motility aspect of this, and we're treating those patients as gastroparesis. So most of the patients, even for a diagnostic EGD, are getting general anesthesia for that. We're rewriting our whole algorithm and approach, and it is something super important to recognize for patient safety, because they will have food. Days, full NPO, liquids before, there will be food in there, and you have to take that into account. Would anybody else do anything different?
We're doing the same thing. It's still a process. There's discussions ongoing with our anesthesia department, but it seems like it's favoring intubating all patients.
All right, Toby, training for ESG. What's, people usually would go to one of these centers and spend a couple days. Some places require that you do the boards, the bariatric board. I mean, it varies, it's all over. But, this is going to gain interest, obviously, even in the community, especially if there's going to be a CPT code. Because, as you said, money drives a lot of things. So, either your own experience, or what do you see societies or other places kind of saying, well, this should be kind of the standard, because that's what we have for EUS and ERCP, et cetera. So thoughts on that?
Yeah, that's a great question. And I think it'll be better defined moving forward. But right now, we're currently dealing with the Wild West. There's no real guidelines. I'm not obesity medicine certified by choice, but I've done years of endoscopic suturing and therapeutics. I think if you look at programs around the country, at Harvard, there is a dedicated bariatric endoscopy fellowship, which I think is paramount. But I also think it's a tricky situation, because if you're going to be a therapeutic endoscopist and a bariatric person, and you're going to do 2 one-year fellowships, the first year out as an interventional endoscopist is hands down your toughest year. So if that first year out is your bariatric endoscopy training year, you lose a lot of skills and you lose a lot of learning. So I think this will be defined by our leaders, Dr. Thompson, Dr. Kumbari, but something has to be defined, especially with the CPT code coming soon. Because right now you have surgeons doing it. One of the GI providers in the country who does the highest volume is luminally trained, did not do interventional endoscopy, and he's done over 2,000 procedures. So I think there's avenues to define this, and hopefully a white paper will come out soon.
Comments from the panel?
The only thing I'll add, we don't have much direction from our societies, but currently there's one device available for ESG, and it comes in a platform by the company. the company, in order to approve you getting access to this, requires you to undergo their training, and it's by invitation only. So they are looking at your volume as well as your abilities. So while it's not a technically difficult procedure, there has to be some background of expertise with suturing, whether that's closure of fistulas or whether that's stenting, stent fixation and things like that. But you have to be already facile with the device.
No, I agree, yeah.
And that's true,
Yes.
but it is a company.
Yes.
And they're gonna, it's not guidelines.
But there are avenues for additional training and seeking out, obviously, if you want to do that. Yes, please.
Hi, I'm a GI psychologist. I don't think this is on. So I'm just curious what you're doing at your institution. And beforehand, who are you utilizing and what are some of the processes for input from a behavioral therapist?
Yeah, we have our own GI psych as well. So every patient that is being considered for ESG and they're meeting the checkpoints are seeing GI psych throughout. So every person sees it. I think you have to do, and I think that as we talked about this last question from Laith, and as Roberto alluded to, it's not the technicality of the procedure, it's all the background work and the work going forward to help ensure outcomes, positive outcomes that needs to be there. And maybe I went over it too quickly, but to have a good bariatric program, endoscopic bariatric program, you have to have behavioral, you have to have dietitians, you have to work in collaboration with your GI surgeon or your bariatric surgeons, because their volume is going to go up once they realize that they want to be your best friend, and you can work in collaboration to ensure best patient outcomes. So you have to be a key part of the algorithm.
Yeah, and I'll second that. I think a lot of places that want to start this, the biggest challenge is convincing the surgical colleagues that this is ultimately, for the interest and the benefit of the patients, and it drives up volume and it's good care, and it is obviously a collaboration. And we have to learn from the surgeons. They all have these weight loss clinics that they do all these things in order before they get to the surgery. So, Eugene, a question for you. So there was some recent guidance from the societies about duodenal stent versus surgical or USGJ, and it's been saying about 6 months. If the predicted mortality is within 6 months, then maybe it's best to put in a duodenal stent. Versus if it's longer than that, then maybe a surgical or EUS GJ. But there wasn't enough evidence at the time about the EUS guided GJ. So, because that's the time frame that people think that's when the duodenal stent starts to get clogged, etc. Doesn't talk much about, though, like as you alluded to in your presentation, the gastroparesis aspect and how that. So, for you and the panel, if you talk to your oncologist and they still think, well, unfortunately, this patient probably has 2, 3, 4 months and not a year or two. What are you doing? So,
Yeah, I think it's a good question, and I think it's an evolving process. I actually find that a lot of patients very early on have instant stenosis from ingrowth, and they don't do well short term, and I think we're evolving to doing more EUS-guided gastrojejunostomies. However, I don't poo-poo duodenal stenting just yet. I still find that it's still a good procedure to go to as a first line, and some patients will do well. I just think that a lot of these patients need to be reassessed very quickly, and a decision should be made. Now, I usually will stratify patients. Those with proximal duodenal obstruction, I find that it's very feasible to do duodenal stenting. Those with uncinate malignancies, they have a D3 obstruction. I really try not to stent those patients because that would make it more difficult to do EUS gastrojejunostomy. But I do like to stent these patients, and those with concurrent biliary obstruction, we try to do a coldocoduodenostomy, especially those that are not going to be resectable. But if they don't do well, we're getting more and more quicker to placing an EUS gastrojejunal stent. And all of the patients that we've done have done well with it, I think both in short term and long term as well.
I totally agree. So the only caveat I would say is your question about, expected life. If it's short term, I go with a duodenal stent, especially if it's proximal up front. And I know it's potentially another procedure, but my thought is, okay, duodenal stent's a relatively straightforward procedure, limited risk. If they occlude that stent and there's some, increased aspect of life or life expectancy, then you can consider GJ, or you could re-stent them. And I think it's just a safe approach. But I agree with Eugene, totally.
I think all of us have more experience, and as anything new, there's always that fear of hurting the patient. And I think as more tools and more techniques and more training becomes available, I think we'll gradually all get more comfortable. I still remember one of the first ones I did, which I presented at a meeting. It was totally occluded, and the patient had altered anatomy, and I ended up in the colon. And so it is what it is, unfortunately. But the patient did well. Surgery is and you have to have your surgeon as a backup, because especially in the beginning of these. So if the stent mal-deploys or something, at least your surgical colleagues are on board. They're with you with it, and then they'll support you if something bad happens. You want to keep that relationship. Fadi.
I have a quick question for Toby. So with this surgical sleeve, there's that small percentage of patients who have this angle, and you have to pneumatically balloon dilate them to fix it, right? Now, would you see that with ESG, or for any other reason, do you ever have to cut the sutures because it's too tight or too angulated?
Yeah, so you may need to cut sutures because of being too tight, and you can probably do that within the first 4 weeks of the procedure. And Merit trial did show one patient that was not progressing by oral intake, so they had to have an intervention. But we don't really see the same thing that happens with sleeve gastrectomy. And yet, at the expected area of the incisura, we don't usually see a stenosis there, or a turn, or an angulation. And the big difference is the stomach can accommodate and move a little bit easier because we're not de-innervating anything. Where surgery, you're losing your angle of his, you're losing your fundus, and you're cutting out 70% of the stomach. So that's where you get into stenosis, ischemia, and everything that follows, all the headaches and morbidity that follows afterwards.
Okay, thank you.
Yep.
All right, last question, Roberto. You presented the AI data, and we keep hearing about it now for 3-4 years, and it's conflicting. But it's interesting from the fellowship standpoint. It seems to increase when you say miss rate, basically what you're saying is the increasing adenoma per patient is increasing, because when you're doing it repeating, you're finding more, so your miss rate is going down. So are you guys gonna implement this? Do you have it? Are you bringing it for trainees? We personally have been looking at it to bring it to one of our outpatient surgical centers, if you will. Obviously, there's a lot of cost involved, relatively speaking. So I'm just curious to know what all three of you, start with you, Roberto, do you feel that's a good investment?
I think it's an evolving field. I think almost can't get away from AI. From a fellowship standpoint, I think it's one more reason to get it. When you have a fellowship, it's nice to have these kinds of data. Now, this specifically looked at the CAD-I platform, which is a little bit different than the one that's available currently with us. Having said that, these are evolving technologies, and as we get more, as the software gets better and better, it's just going to continue showing that much of a difference. We are looking at, actually, we currently have it at our institution, and that's kind of new, so we're still evaluating how well it works, but definitely, I think if you were a patient, I think you would opt to have a colonoscopy with that on.
I tend to be old school. I still think it's not prime time yet, but with that said, I think more data is going to come, and I think we're going to be surprised at the role that this is going to play. I'm just not there yet.
I'll do whatever Dr. Stidham recommends in his next talk.
Great. Okay, with that, we'll conclude our session. So thank you all for staying. And our last talk of the morning, thank you guys, is Ryan Stidham, and he's going to talk to us about AI and GI. And I think he's going to expand a little bit more than that. So Ryan. All right, thank you guys.
Great, thanks. And thanks again to all the organizers and sponsors. Congratulations to the hardcore group that has remained here for all the learning opportunities. So thanks. And thanks again to the organizers for giving me a chance to share some things with you. We'll talk and we'll wrap this up with hopefully something entertaining and maybe more thought-provoking, perhaps. And just thinking about artificial intelligence and what are we going to do with these tools, right? And it's definitely going to change our practice to some degree in the short term, to an enormous degree in the long term. These are my disclosures, which include some things that have to do with endoscopy, though I'm not showing any of that here today. A lot of people are not that interestingly excited about AI. There's a lot of buzz, they hear a lot of things, but some of the comments I get from seasoned clinicians are, I've heard all this machine learning stuff for 20, 30 years, big data, blah, blah, blah. I haven't been impressed. And that's understandable, right? So since the introduction of electronic medical records and the digitization of a lot of our data, we've got these huge data sets now, like in your own health systems, such as, like Epic or Cerner or NextGen or the EMRs. Plus you've got all these other administrative data sets from Optum and NIH. We've got all this digital imaging data, right? Now we've also got multi-omics data and biometrics. So we're swimming in data, right? There's like an ocean of information and all this promise that big data is going to solve all of our problems, right? In healthcare, it's going to tell us what to do for every patient. Everyone's going to be cured. Yay. And then you slam all this data into a bunch of expensive servers and equipment that all of our institutions pay for instead of compensating us. They just buy all these machines, and they say machine learning is going to figure this all out. But to date, the output hasn't been very good, right? Like, think about all of the alerts in your electronic medical record telling you, oh, your patient needs colon cancer surveillance. Well, their colon was taken out years ago. Or, have you screened this patient for HCC? And it's like, yes, the ultrasound was done somewhere else. So the output and the utility of this to date has been pretty poor. So why is that? Well, if you think about what it is that we do, there's so much information that we collect when we're rendering care to an individual and to an entire population. So when you're performing an endoscopic ultrasound, you have to know something about the patient. You have to know their comorbidities. You have to understand their risk tolerance. You have to understand other health information pieces and integrate all that information. You're changing how you do the procedure based on their prior imaging, the real-time views. And then it's not just your opinion. You're often aggregating your intellect, knowledge, experience, and real-time data with the opinions of an entire group, right? So this is something that machines really haven't done a good job at, This is certainly the case in the procedural aspects of gastroenterology. But also if you think about, other clinical spaces like an IBD, sure, you can have a data set that says this person has severe colitis, right? But severe colitis can mean many different things. All of us have patients with severe colitis that's mild severe colitis, or we have severe colitis, and they may be treated differently. Or maybe in your discussion with the patient, they have different aspects or concepts of what they want to do to manage the disease. Maybe they want medical treatment, maybe they want surgical treatment, right? So all the different pieces of data and information and all the encounters that we have, the journals that we read, our experience of disease, those are the pieces of information that the machines don't have, at least they haven't had to date. And this is what has made our job and other knowledge jobs so difficult for machines to help us with. But that's changing. And it's changing because the capability of artificial intelligence is rapidly evolving such that it's beginning to start to acquire information the way that we do. Think about computer vision, right? Like, I love my Roomba. That's like dollar for dollar the best investment I have. I work at an academic center, so I can't afford a Tesla, but they're pretty cool too. And you know, computer vision is now basically giving machines the ability to see in some ways the way that we do, categorize information and have context. This is true in kind of the industrial world like here, but it's also true increasingly in medicine. Natural language processing we'll talk about and is more or less teaching machines to read. Just because in your electronic medical record you have hundreds of millions of pages of text, it doesn't mean that machines can extract that information and understand what it means. But those capabilities have come a long way and I think are now ready for machines to actually do this. When I was 6, this was my favorite movie. It was called Short Circuit. Awful movie, but they taught this little machine, Johnny 5, to read. That's for any 80s buffs. But increasingly with language, we now have large language models which allow machines to understand text and to understand the context more. And increasingly, you put all these things together, and we're seeing machines that have the capability of self-learning and some aspects of reasoning. And it's getting pretty good. So let's talk about imaging, right? Because a lot of the technological advances in artificial intelligence have been imaging heavy because a couple different techniques have been developed, such as convolutional neural networks and transformer networks that are very good at classifying images and understanding images. And so for endoscopy, for histology, and for cross-sectional imaging, machines are doing an excellent job at replicating our own impression, organizing that information, and even seeing some things that perhaps we have a hard time seeing. How does this work? It's relatively simple, right? So you've got multiple different image modalities. It doesn't matter which one it is because the processes for machine learning for understanding images are the same, right? So you can take a still image or a stack of images or a full video, and then you can pair that single image or image series, pair it with a diagnosis. Do they have sclerosing cholangitis or not? Pair it with the presence of a therapeutic change, the prognosis, maybe your own qualitative judgment. You look at the CUS and it's good or it's bad, or it's mild, moderate to severe. You can program all of that. And this gives you the opportunity to actually program in your own experience and judgment. Even if you don't know how to quantify it, the machine will figure that out. And so you can pump this into, typically it's a neural network, a convolutional neural network. There's a bunch of other methodologies, but this is the premise behind what these machines are doing. So one of the first kind of clinical applications we've seen in imaging, and everyone in this room is familiar with this, is the Medtronic product GI Genius. I have no relationship with them. And the idea is for this to help ADR. And in the last session, we also heard about some CAD-I as well, looking at using artificial intelligence to try to help trainees, right? So the idea is you train a machine learning classifier that's seen millions of images of polyps, it's seen millions of images without polyps, and it can identify where on the screen a polyp exists. This is the illustration. But one of the things that we have to think about is AI may take us in directions that we don't necessarily anticipate. So sure, we can see more polyps, but maybe we're seeing hyperplastic polyps. Are we training a generation of young endoscopists to spend their time picking out little 2-millimeter hyperplastic polyps that don't matter? I don't want to do that. Are we completely wasting our time? Are we having falsely elevated ADR rates of 50% because we're seeing innocuous lesions, right? There's also the possibility, though, not just with this polyp detection technology, but with all AI, for us to become a little bit complacent. And I call this like AI-enabled complacency. And if we stick with this polyp detection example, this is a study that I think illustrates this concept. This is from Yuri Kopolov's group in Israel. And what they did is they took the GI Genius system and they implemented it in their entire medical center for 6 months. And they looked at the polyp and ADR rates before implementation and after implementation. And the green bars are their rates before AI, and the orange rates are 6 months after AI, not right away. Interestingly, in the first month, across the board, polyp detection, adenoma detection, and advanced adenoma detection was all better than before. So it helped initially. But over time, the orange bars show a statistically significant drop in the ADR. Why did that happen? And this was across multiple centers and I think 12 different endoscopists at multiple different sites and thousands of endoscopies, right? So a lot. People started relying on the AI. They started waiting for that little green box to show up. And if they didn't see the green box, then they assumed that there was no polyp there, right? They got so comfortable with the AI and assuming that it was going to tell them the right thing to do that they started missing polyps. Maybe they didn't look around the corner, maybe they didn't retroflex, maybe there was a little bit of stool present and didn't clear it out. So I think these things can be overcome, but the takeaway point here is that we're going to have to be careful, as every aspect of our practice is going to have some AI component, to not let this happen and to always be aware of the limitations of these devices so it doesn't take us in the wrong direction or we become too reliant on it. But AI can still be helpful. I think it's still a positive story, especially in imaging, especially for seeing things that are difficult to see. And these are just a few examples. This is a system from Yoshi Mori's group, who was in Tokyo, but he moved to Norway and got recruited there. And this is a system that he developed for detecting IBD-related dysplasia. I can see adenomas just fine. I don't really need help there. But I could use some help with dysplasia, like flat dysplasia in the UC or IBD patient, right? So on the right is the real-time video. I don't really see anything. But on the left is more or less a GI Genius-esque system, but trained to look for dysplasia. And you can see the little green box in real time saying, I think there's something here. I didn't really see very much, but once it brings something to my attention, switch to NBI, aha, maybe there is something there, apply some chromo, and then there's clearly a lesion, right? The point here is not that, hey, we've got some dedicated system to see dysplasia. It's the idea that AI can help us do things that are hard for us to do. And this is one example. Another example is in cross-sectional imaging. So I'll stick with IBD because that's kind of clinically all I know very well anymore. And fibrosis is an issue. When we're trying to figure out in a Crohn's patient how much of their disease is inflammatory versus fibrotic, we kind of have no way to know. We do an MRI, we do a CT enterography, we try to sort it out, but we're kind of just guessing, right? So a group in China performed radiomics, which is more or less taking the CT scan, segmenting it into its constitutive parts, and then pulling out all kinds of features from the imaging. Some of them you would understand, like brightness or the degree of contrast. Others are difficult to understand, things like entropy and kernel correlation, which we don't really have a cognitive analog for. And they looked at surgically resected specimens that are fibrotic versus normal. And when they compared the radiomic model for finding whether or not fibrosis was present compared to the radiologist impression, there was no contest. And radiologists would admit, we just can't tell. We know there's disease there, but it's a very difficult thing to see. The machine in this very specific case was able to discern the patient that was more scarred versus more active inflammation. And so that has a lot of therapeutic implications. And I think this concept is applicable in multiple other subspecialties within our field. What about making difficult measurements, right? So there's a lot of scoring systems that we use. Think about the Mayo score for UC or for evaluating Barrett's esophagus, and we have good scoring systems, but there's some subjective variability between reviewers, and sometimes the scoring can be a little bit complicated. But machines can be used to standardize those scores as well. And here's an example from Oxford looking at Barrett's esophagus. And this is a still image from a video, but they're able to automatically segment the esophagus into its constitutive parts. So what you're seeing here at the top part of that image is the native endoscopic still. The middle image is actually a segmentation mask, where the machine is able to define the different key anatomic regions in that image. And then the very bottom is now an overlay of where the machine believes lumen is, squamous mucosa, et cetera, that has to do, in this case, with Barrett's. And from that, when you do that in the entire video, you can actually generate what you're seeing in the very bottom. This is an example from a patient of a three-dimensionally re-rendered esophagus. So you performed the endoscopy, the video is captured, and it's converted into a 3D model. And with that data, you can then make all the measurements that you want. In fact, you can make a lot of other measurements that are just impossible for us to do by hand. This is also true for IBD, so the Mayo score, SCSCD score. Our group has done a lot of work with this as well with many others, and basically shown that, grading the severity, endoscopic severity of IBD, we can actually now with the machine instantaneously match what central reviewers would do. So this has a lot of impact in clinical trials, but also in day-to-day practice. And in Michigan, one of the things that we've now implemented is taking that automated GI image analysis and pump it right into the EMR. So we have a system in Michigan called IBD Access, and all of our endoscopy sites have background recording now for our IBD patients. What you're looking at in this table are every time an IBD patient has a colonoscopy, they have an individual video identifier. It automatically goes to our servers, and you're seeing the predicted Mayo endoscopic score. That's the MES prediction on this table. We have a bunch of other metrics that we generate, such as how much of the colon was a Mayo 0, a Mayo 1, a Mayo 2, a Mayo 3, what's the quality of the video, et cetera. And that information now is part of the electronic medical record. This has been super helpful for us in a lot of ways because it gives us that objective endoscopic score without the endoscopist having to do it. It's standardized. It's done passively in the background. No one does anything. And it pops up in our EMR now if we want that information. This has been really helpful for us because we're like super behind on colonoscopies, like the demand is too high, we don't have enough endoscopists. So a lot of our endoscopies may not be done by the performing or by the clinician themselves. So this is really helpful for them to kind of get that information. And I think these types of systems are going to propagate across all of endoscopy and image analysis. So, our objective is actually, we have an ongoing project to expand this throughout the state through multiple sites. So all over the state of Michigan and increasingly throughout the country, we'll push endoscopic imaging to our cloud and have this passive background video capture for places that have interest in this. So it lets you manage whole populations. But like Andre Agassi said, if you remember him, maybe I'm getting too old, that's too old of a reference, but he had an ad campaign where he said image is everything, right? He was the tennis player and it was like a campaign for Canon cameras. But there's more to our jobs than just the endoscopy and the CT scan, although I try to make my jobs just that. But sometimes we have to talk to the patients and read the notes and read all the notes from the other clinicians that have worked with them. And that's hard, right? You need to put the patient into clinical context. And you've got all this information here to tell you everything that you need to know about the patient, all their narratives over time, but it's kind of trapped in the electronic medical record. The way that we can get that information out, though, is you can all sit down and read thousands of documents, which is how we've done this for the last 200 years, or we can have the machines read it for us. Natural language processing takes text data, which is unstructured. This is a CT enterography report, okay? So all the information that you want to know is in the text about a given patient's scan. But the problem is, this is not structured in a way that artificial intelligence or machine learning can use. It's not in like a clean, nice data table. So more or less, that's what NLP does. It structures the information to give you what you need out of that note and organize it. Organize it by date, time, finding, severity, and to give you some kind of inference as to the confidence of how sure is the machine that it's understanding what it read. How does this work? Well, there's lots of different NLP systems out there, but the premise behind it is, I'll kind of walk you through it here. Think of this sentence, like you're reading a report, just one sentence. The patient underwent a CT scan in April, which did not really reveal any lesions in his liver. To get a machine to understand this is really complicated. I've been working on this for 15 years with much smarter people, and it's hard. But the field has made progress. The machine will take this sentence, it will break it up into constitutive elements, all that grammar that you learned early on, like past participles and non-agreeing, like subject-verb non-agreement. You can program a machine to understand this. You can break the sentence up into its constitutive parts. You can do what's called a POS tagger, a part of speech tagger, chunk concepts together. And at the end of it, you can pass that through more or less a dictionary that's actually maintained by your tax dollars. The National Library of Medicine maintains a lookup database called a metathesaurus that takes those concepts and actually maps them back to some kind of to organize the information. And so that sentence is ultimately converted into what you see at the bottom here, this kind of encoded version of that sentence that is now in a format that the machine can understand. So the machine now says, okay, this sentence is basically saying the patient there was a CT scan done, it was done on the patient, a lesion was noted, but they said that the lesion was negated, it was not there. That's how the machine would ultimately see this. So the power of doing this is we kind of talked about imaging examples already and how you can extract information, replicate expert opinion, get new types of measurements that are just not feasible for us to do. But now you can add that text information to it, cram it all together and organize it, and now you've got a degree of granularity and specificity that we didn't have before. So you're not describing a patient with some administrative codes and CPT codes in their labs. You're describing them with like the narrative text. You're describing them with the images. And I think that this is what's going to power meaningful AI immediately. So if we take that and we think about how is this going to touch our practice, it's hard to divine or speculate even a decade away. I don't really know what's going to happen. But we've got some ideas of what's going to happen in the short term. First of all, better information is going to lead to better prediction. So all those predictive models, suggestion systems that frankly I found annoying and insulting when the EMR kind of throws these pop-ups up. I hate that stuff. But now it'll have better information, as I just described, and so I think predictions will get better. So we'll have an entire technology stack in gastroenterology that's going to be leveraged for better predictions. Automated image analysis, pulls in the lab data from your EMR, reviews the text in the notes, perhaps is even looking at biometric data from your patients. And you'll start getting probabilities and estimates and confidence in your automated decision support systems that are actually going to help you. Don't tell me what I already know. Help me with the decisions that are tough. So expect these decision support systems to actually become useful. You'll want to use them. That's my prediction. But some other things to consider about our practice is the public perceptions of AI and perhaps some surprises. This is, I've worked with someone named Nicholson Price. I don't know if I wouldn't expect any of you to know him, but he's a lawyer at the law school at University of Michigan. And we worked on a study a couple years ago where we put together, he did all the work actually, 2,000 jurors, and we gave them simulated cases of AI because we're anticipating AI is going to be everywhere. It's going to be in your decision-making process. It's going to be in your endoscopy suite. And we wanted to give these jurors some scenarios and to see what they would say. So here's a scenario where the AI recommends a standard of care, but you, the clinician, deviate from standard of care. The outcome is the patient was harmed or had something bad happen. Maybe it was a decision in like a cancer treatment process. Maybe it was a decision on doing a procedure versus not a procedure. What did the jury think about that? No surprise, the jury thought the clinician would be liable because the clinician went against standard of care and there was a decision support system that was telling them that they should do standard of care. That's not interesting. Situation where AI recommends standard of care, clinician follows the AI recommendation, the patient is harmed. What happens there? No liability. 80% of the jurors wanted to know, did the FDA, who by the way knows nothing about AI, they're learning, but they know nothing about what to do with this. All the public wanted to know is, did some government body vet this and validate this, whatever that means. I do this all day, and I don't know how to validate this. But a jury that said, well, it's validated, who cares? I mean, doctor was just doing what the machine said. So it's surprising how much trust the public has in these AI systems. I would think quite the opposite. So this really surprised us. And this last one I think is the most interesting. AI decides to go outside the standard of care, recommends something against guidelines. The clinician rejects the AI and says, no, we're following guidelines. Patient has a not great outcome. I would have thought that the jury would have sided with the clinician who did standard of care. It didn't. It was mixed. It was just about a 50-50 mix between those who felt that the AI was liable versus the clinician was liable, which is crazy. I wouldn't have expected that to happen, especially if this clinician was doing standard of care. People are really trusting this technology. So a lot of surprises are coming. Here's some other tools, and this is available right now. Microsoft is developing a medical division. I consult with them, and I know some of their research scientists, and we've collaborated together. Ambient conversation documentation. What is this? You'll like this. There's a couple different systems. One's called Nuance DAX. Other one's a company called DeepScribe, which I haven't used, but it's the same idea. And imagine in your clinic suite, you've got microphones everywhere. And you have a computer that's listening to the conversation in the clinic suite, and they know who the patient is. They know who the family member or the person with the patient is. They know who the treating clinician is, and they know who maybe the clinician's assistant is. And all of that information is transcribed. So at the end of your clinic visit, you have a transcription of everything that was said by everybody and who said what, when. Interesting, right? Well, what happens when you take that information and you pump it into some of the new NLP-powered chatbots? What can you do? I would predict within the next 5 years, no one in this room will be documenting. I'll put some money down on that. If anyone wants to make a bet, I'll make a friendly wager, but I think it's going to happen. This is from Peter Lee, who's a friend of mine and the medical director for Microsoft AI Medical. What you're looking at is an actual real transcript, not a mock-up. The text is pretty small. But this is the actual transcript from a patient encounter. And you can see like the transcript, what the patient said, what the clinician said, and the flow of this. You can then ask a chatbot GPT to say, I want you to take that conversation and make a SOAP note for me. Write my note. Walk out of the room, write the note. And this is what it would generate. Nothing. Frozen slide. AI failed. Don't worry, our jobs are safe. This is really impressive. I really need this slide to work. What do you think? So you're saying there's a chance? So if we can't get it working, take my word for it. This transcription is translated into a whole SOAP note instantaneously, which is wild. We might have lost, we might be getting out of here early, guys. I have no other skills or talents except this, so I'll freestyle. So you all get the concept here, right? Not only in this particular example, which you're just going to have to take my word for it, not only will it write the note for you. Trust me, the note is good. It's very good. It's probably better than a note that any of you would write, at least better than a note I would write. You can also then say, hey, can you send a letter to that, working on it? Okay, just let me know. I'll keep checking in. You can also ask it to, are we going backwards? What do you think? Want to try it? Come on, baby. Come on, baby. Survey says, oh, yeah. Great job. Thank you back there. This is the note that it actually generated and did this instantaneously. It took us longer to pull the slide up than it did to generate that note. But thank you very much in the back. So this is the actual note that it generated from that transcript. And you can see it right here. In fact, this system is going to be integrated. They've already partnered with the Epic electronic medical record, and this is going to be integrated directly into Epic, which is pretty exciting, right? You can write the note, you can have it generate those orders, push those orders directly to your EMR, and check this out. From that conversation, they asked the system, hey, can you write a letter to mom? Mom's worried. Just let her know what's going on and based on what we talked about. I guess I'm not going to ask too much. What else can you do with natural language processing? And you'll all see this in your practice, chatbots. I don't think the in-basket's going away yet, but we are all praying that we can use chatbots to eliminate your in-basket and all those messages and have a digital assistant to answer the majority of them for you. This is already actually being implemented by a couple major health systems, including Corewell. UCSF actually is using real-time chatbots for patient education for bowel preps. So the patients are not calling the clinic. The chatbot is talking directly with the patient and giving them instructions on how to manage nausea or slow down on your prep, speed up, etc. This particular example is from a company called Conversa. I have no relationship with them, but they're also doing automated patient follow-up. The system by itself will reach out to the patient to collect information for you. And then finally, patient surveillance. Maybe you just want to check in on your patients and have the machine do it for you. It'll go out and collect blood pressures, symptom questionnaires, and have an interactive conversation with the patient as your surrogate. So what's GI practice look like tomorrow? Well, I think there's going to be, in the last 3 slides here, some general kind of concepts. First of all, automated expert level image analysis is going to be here. So all of our expertise is going to be programmed so that you get standardized scoring and standardized assessment of images, right? This is going to give us higher reliability of test interpretation. It's going to give us instantaneous medication use justification, especially for IBD. I don't want to mess around with some insurance company or payer to say the patient's severe. But if I have a validated automated severity detection system, I think we'll just automate the entire prior authorization process. And I think this will also allow for standardization of care across large health systems, right? So all the different, everyone's contribution in terms of opinion can be synthesized into a institution level standard. Second, I think this idea of using NLP for automated patient collection is going to be really powerful, and you're going to see it in all of your clinics very soon, right? So gone are the days of reading all these charts and outside records. The machine's going to do it for you, and it's going to organize all of the information, right? So you're not going to have that sad life reading notes. You know, you're going to look, you know, healthy and happy with your legs up and, you know, very fit. I'll stop making those comments. The machine will collect information. It's going to do it for you. It's going to clean it. It's going to organize it. And it's going to reduce information overload. If you're a therapeutic endoscopist, you're not going to care about all that other garbage information that's not useful to you. Maybe it's useful to someone else. The machine will be custom to what you need and show you only what you need to see to focus your attention. And then it's also going to hopefully give you more time to talk to your patients and just engage with them. Like render medicine as opposed to doing administrative work. What's the bad news? Not too much bad news. So I think we're going to use all of these tools to like start stratifying severity and stratifying patients. So where we're going to have to give back here, as opposed to AI taking our jobs, we're going to do our jobs, but we're going to supervise AI like you would a student or a fellow or a resident, right? It's going to manage entire populations for us over the coming 1 to 2 decades. Start figuring out who needs care now, who can wait, who needs what tests. Help us to focus their attention on patients who need care. And I think within the next 10 to 20 years, our practice is going to look more like, you know, some kind of operations center. You're still going to be needed to supervise patients' care, but you're going to be supervising the care of 10,000 patients as opposed to perhaps 1,000. And that's what I think that these technological advances are going to enable for us. So I want to thank all of you for attention and sticking around to the very end and being patient with some of the slide stuff. But it's been a great conference, and thank you all again so much for your attention.
That was great. I don't know, I'm afraid to open this up for discussion, because I don't know if this was recorded, and it is, and some AI somewhere may start doing things, so. But thank you, but if somebody has a question, we'll take it. Dr. Sheikh, if you don't mind coming up here too, please. Any questions? So, I remember as a fellow 30 years ago, 25 years ago, whatever it was, when we had to do a presentation, we had to go to the library, all that stuff. We didn't have all these resources. So if you were asked to give a presentation, you had a month time. Now we expect our fellows to give a presentation the next day. As you said, we're now managing 1,000 patients. With these tools, we're going to be managing 10,000 patients. Before, the clinic was 10 patients in a half a day. Now it's 20 patients in a half a day. That takes a strain on the brain. And it doesn't seem that people really account for that. Their expectation is, well, you have all these things to help you, so you can do more in the same time frame. And I think that's something that is usually overlooked, and that's why, and I personally dislike burnout, because it's not really burnout is when you're expected to do something and you're not able to do it, but reality is we're asking more of ourselves, or we're being asked more to do more. So it's not really burnout, it's basically overuse. And that's gonna only get worse with these technologies. So how do you stop that? How do you prevent that? Just say no, but I'd like to hear thoughts, and maybe you guys.
I want to be positive, because negativity is not good. Yeah. Shane, I don't, as an individual, I don't want any of this. I like my job the way it is. But this is changing every sector for all of us that are knowledge workers, and like the philosophical discussion about what to do with AI, I think is probably beyond the scope of this meeting, and it's Sunday afternoon, so I don't know if we want to get into that. But I don't really know that we're going to have much of a choice, right? So to be frank, these models are extremely good. They're extremely good, to the point where the pushback over the next 1 to 2 decades is going to be everyone's going to publish papers about how good the AI is and it matches clinicians, even though there's going to be nuanced cases where the AI is unable to do some things what we do, or can't appreciate certain nuance that the machine doesn't have the right sensor for or the comprehension for. But you're going to have payers and CMS saying, well, you published 1,000 papers, Ryan, that says that the AI is as good as IBD as you are, so what do we need you for? And then you're going to have a class warfare system where everyone's going to want to see humans because it feels good. They're going to want to see their human, like, clinician. And if you have a lot of money, that's what you're going to do. And if you don't have a lot of money, your insurance company is going to see the AI as much as you want, for free. It's all covered. But if you want to see Dr. Kanukin, you get 30 minutes a year, right? And that's all you get. So I think where we have to push back is on what is the degree of safety and assurance that we have to have from these AI systems for us to agree to supervise them? Because payers and all of the money is going to push to AI because it's cheap and more or less free. And then they're going to push the responsibility back on us. So the contract will have to be, if you want us to be responsible for what that machine says, you have to be positive that that machine knows what it's doing. And so the last point I'll make is, I caution all of you, because you will have vendors coming to you telling you that they've got some AI system that's going to help manage your patients, it's going to help your practice, blah, 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 increase your efficiency, whatever. What most of these systems do is they find the easiest possible patients that are the lowest possible risk. They manage those, and they leave your practice with the most difficult, most challenging patients. So now your half day of clinic turns into the sickest patients that are out there because the AI is managing all the softballs. I need those softballs because my brain's weak. It gets tired. So I think that where I would close on that comment is, it is going to be our job to make sure that the risk for patient safety and efficacy is shared between the clinician and these technology vendors. They don't get to put all the risk on us. We're going to have to share it together. And I think that will be a more equitable system.
Ryan, can I ask you, is that okay if I ask a question?
Please.
Fascinating talk, and I can't think of a better person to give that talk than you. But I'm kind of curious, in clinical practice, a lot of times we rely on nonverbal clues like, oh, my belly doesn't hurt, and then they're kind of, sitting there very uncomfortable. I'm curious, how would these computational systems be able to analyze this and incorporate these things that we as clinicians do naturally? And the second question is, you've presented a lot of data on diagnostic and data incorporation and just computer-based organization. Is there a trend to implement this technology for therapeutics, whether it's surgical, endoscopic, or whatever other modality?
The answer to the second question is yes, right? Because the first kind of couple points I was making early in the talk were, in the past, the problem with AI and machine learning was not, it was not the machine learning models, it was the machines didn't have the data that they needed. And what's changed are basically new sensors and new capabilities that can extract the right kind of information to make better predictions. Your first question, or point, Eugene, was about like all that nonverbal communication. So there's what's called a semantic. There's a sentiment analysis company called CU. And what they do is have cameras in the clinic, and this is for psychiatry. And they are detecting the facial expressions of the patient to try to infer that patient's sentiment. How do they feel? How are they responding to a certain piece of information or advice that you give them? And they categorize that sentiment and incorporate that into the decision-making process. That's all very early, and that's not to suggest that that's completely ready for prime time. But the sensor technology to extract that kind of nonverbal information or other types of cues, that's kind of the secret sauce that's making all this AI work, is having the right information to make those decisions. Because now the model can adjust and incorporate for, oh, when I said the word biologics, the patient didn't like that and they frowned. So now the machine has that as a data point and can shift its recommendation in a different direction. That's the theory, but it's coming a long way very quickly. But a great question. Mark.
Mark.
So that was an amazing talk. It was an honor to watch you do it. When the computer glitched, it tested to make sure you weren't a computer glitching too. So that's what happened.
Well, this is all a simulation anyway, and you're jacked in somewhere upstairs. But go on, Mark. Sorry.
So one of the things when listening to you talk about this and reading about it and whatnot is, all this data is compartmentalized in different areas, and they don't all talk to each other. So how do we get to that point where it's patient-centric, and all like Mark Piper's personal data is combined to let me make a decision based on like my personal risk tolerance, based on things I do with my life in Amazon and Netflix and how fast I drive or how late I get to the airport and those things. Do you see that coming around?
There's a lot of industry that's trying to work on solving those problems, right? Control of information, information security, and just this philosophical concept of, can information be owned? Is it your property or not, right? And this is a big issue. Keep in mind with ChatGPT, which I'm sure all of you are familiar with, everything you type in there goes on their servers and is saved. So if you decide to copy and paste a patient note in there, it knows it now. Keep that in mind. Maybe that's not a problem. I mean, Amazon's listening, we're freely giving information away to social media all the time, and I don't think, but increasingly there's awareness, especially after the Cambridge Analytica scandal in 2017. There's much more public awareness about their personal information and how it can be used in some ways that they wouldn't want. So this is a big push from industry, and it will come, but there's not really turnkey solutions yet. But there's a lot of interfaces here between industry, government, law, to solve that. But I think that'll be another part that's up to us to kind of put up the right kind of guardrails so that this stuff doesn't start doing things we don't want it to do. But it's the security and privacy piece is an excellent point, Mark.
And I think that's where us as physicians, being involved in leaderships and decision-making is going to be more and more critical, because obviously, ultimately, we have an oath, we have an obligation to our patients, and we really should do what's best for them. And what's best for them also means what's good for us, because we're the ones caring for them. And so we have to be part of that decision-making in some way, shape, or form to make sure things don't get out of hand. And the next thing you know, we're just doing what a computer's telling us because an administrator told us. So something for everybody to keep in mind.